Reanne Booker is an oncology and palliative care nurse practitioner in Calgary, Alberta, Canada, with over 20 years of experience in oncology. Ms. Booker currently works with the Palliative and End-of-Life Care Services program in Calgary, Alberta, Canada. She is also working on her PhD in nursing through the University of Victoria. The focus of her research is on the integration of palliative care and oncology. Her clinical and research interests include symptom management, sexual health and cancer, the integration of palliative care and oncology, and medical cannabis in cancer care. Ms. Booker is the president of the Canadian Association of Nurses in Oncology. So welcome and thank you very much for being here, Reanne.
Thanks very much, Miguel, for the introduction. I'll just share my screen here now and get this rolling. And I just also like to thank the conference organizers for the invitation to speak today and to thank everybody who's joining us online. It's wonderful to have you all here. So again, I've been just astounded at the content of this conference. I think it's wonderful. Very incredible presentations have been happening. I think, it may seem counterintuitive to talk about palliative care when there's so much progress being made in disease-directed therapy, particularly for thyroid cancer. But I think that palliative care is something that we should all think about, even if there isn't a chronic illness or a serious illness in the background. I think it's something that we should all keep in mind. And I'm hoping to convince you of that in the next few minutes. So I don't have any relevant financial disclosures to discuss. I've received some funding for my PhD studies through various organizations in Canada, but not from industry or pharmaceutical companies. So today I'd like to speak with you about what palliative care is, what it isn't, and how it can help after a cancer diagnosis. And I also would like to talk about resources that are available for family members and patients and loved ones after a cancer diagnosis. So just to situate myself, I am in Canada, Calgary, Alberta, Canada. And I was mentioning just before the session started that we actually have been getting quite a bit of snow lately, and it was -13°C this morning, so quite chilly. But I live very near to Banff, Alberta, so very close to the Rocky Mountains, a very beautiful place to be, even if it is somewhat cold at times. So this is a really busy slide, but I just wanted to bring your attention to the fact that palliative care, this is the World Health Organization definition of palliative care, and it's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. And so historically, we used to think of palliative care as being synonymous or the same as end-of-life or hospice care, but we know now that palliative care is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiotherapy. So it's no longer reserved for end-of-life care only, and certainly can be delivered alongside even curative intent therapy. The roots of palliative care can be traced back to Dame Cicely Saunders' work in Great Britain in the 1960s, and she's credited with developing the modern hospice movement. In 1970s, it was a Canadian physician, Dr. Balfour Mount, in Montreal, who coined the term palliative care. And part of the motivation for that at the time was that there was some negative stigma associated with hospice. And so palliative care, palliative is meant, the root of the word is to cloak, and it was thought that palliative care might be more palatable compared to hospice. But I think we're still seeing now that palliative care has gotten the same negative associations with end-of-life care. So what is palliative care? Well, as I said earlier, it's an approach that improves the quality of life for patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, including physical, but not just physical, also psychosocial and spiritual. So very holistic. And to compare and contrast the differences between palliative care and hospice care. So palliative care really could be integrated anytime. It's not reserved for end-of-life care only. It's meant to provide an extra layer of support for people with any stage of cancer. Hospice care is a specific type of palliative care, and it's provided to people with later stage disease, and usually when prognosis is in the neighborhood of 6 months or less. Palliative care can be provided really anywhere. Hospice care can be provided in multiple areas as well. And there can also be specific hospice facilities. In both situations, we're looking at interdisciplinary team members providing care. So that can be nurses, doctors, social workers, occupational and physiotherapists, pharmacists, spiritual care providers, psychologists, really to get to that comprehensive assessment and management of symptoms. And again, palliative care can be started anytime after diagnosis. Now, hospice care is usually reserved for closer towards the end stage of the disease, towards the end of life. And really in both palliative care and hospice care, the focus is on improving quality of life for patients and their caregivers, and also really providing support for caregivers as well. So the goals of palliative care, as I mentioned, to help manage symptoms and side effects of disease and treatment, and really trying to optimize quality of life, helping to manage practical concerns, coordination of care, addressing spiritual and existential concerns as well that can be so common and often overlooked. And then again, really ensuring that there's support for caregivers, family, and friends. Again, where is palliative care provided? It could really be provided anywhere. So you can see palliative care provided in the home, and we have palliative home care programs with palliative home care nurses and staff that can provide care in the home. We can provide palliative care in hospital settings, in long-term care or supportive care living settings, in hospice facilities. And these are just some examples of the hospice facilities here in Calgary. We've got this beautiful one called Foothills Country Hospice that is located south of Calgary, and it's got stunning views of the Rocky Mountains. And this is another hospice, Agape Hospice, that's located in the city as well. And so those are settings where if people are not able to manage at home anymore, they can go into a hospice facility and receive palliative care and specific hospice focused care towards the end of their life. So why is the integration of palliative care and cancer care important? We know that there are multiple issues that cause suffering after a cancer diagnosis. There can be physical symptoms for sure, and definitely in the acute phase after diagnosis and while someone's going through treatment, the physical component can be quite profound. And again, towards advanced disease or end of life, the physical component can also be quite significant. But also the psychosocial and spiritual and practical issues are very common, and these can sometimes persist for years beyond the completion of treatment. And I think this is where, again, some of these needs are sometimes under-addressed and under-managed. And so definitely we know from many of the studies we've done that patients need help with these concerns long after treatment is finished. And then there is a specific area here as well, where we know that end-of-life care and death management and bereavement care and loss and grief are also really important needs for people. So again, this is just a different diagram showing that there's all kinds of different needs: informational, physical, emotional, social, and spiritual. And so again, this comprehensive nature of suffering is met in palliative care by the comprehensive assessment and management that palliative care can provide. So who provides palliative care? Well, if you look to the very center here, we see there's a patient, and families very often are providing palliative care, whether they know it or not. But very often it's families and loved ones. But again, you can see the multidisciplinary nature of the team. And I think that's one of the most unique aspects of palliative care, is that interdisciplinary nature, with different members of the team providing different expertise and allowing the patient's needs to be addressed in a holistic and timely fashion, and really kind of supplementing the ability of what the family can provide, and maybe taking some of that burden off the family. And there's different levels, I guess I would call it, of palliative care. So there's primary palliative care, and really this should be basic care that any provider can give to patients and their loved ones. And then it gets a little bit more tailored to specific and more complex needs, where we have specific or specialist palliative care teams and specialist palliative care units. Those are often located in hospitals that can really kind of focus on the complex issues that some people have throughout their illness and disease trajectories. And so historically, we used to think that, once disease-directed therapy was finished, so there was no longer the possibility of curing the underlying condition. Once that happened, then somebody would start palliative care. And then right again towards the very end, we would have hospice care. But we know now that if we start palliative care early, we can really provide a lot of benefits to patients and their loved ones. So again, this bow tie model was created by a physician in British Columbia, and shows, the focus maybe at the time of diagnosis is very much on disease management, and definitely, unquestionably, if cure is possible, that's where the focus is. And so that's, focusing on treatment and focusing on getting rid of the cancer. But there is definitely still a role for pain and symptom management. And then if there comes a time where the disease is no longer responsive to treatment, or disease-directed therapy is no longer working, that's when we can shift the focus to managing symptoms more as the focus and comfort, and then towards the end of life care and bereavement care. And so there was something else I wanted to say about that. I'm trying to think of what it was, but it'll come to me. But again, historically, we used to think of palliative care being involved right at the very end, when there was no longer any curative intent focus. That's what it was that I wanted to say, is that I've often heard people say, there's nothing more we can do for you. There's nothing more we can do for the disease. And that, I don't like that language, because I think there's always something that we can do. Sometimes we have to shift the focus of what the goals are. And so if the goals are no longer curative treatment, then we find new goals and we work as hard as we can to achieve those goals. And so there's always something that we can do. And so we know from research, again, that has looked at integrating palliative care early, that there are many different outcomes that improve if we integrate palliative care earlier in the disease trajectory. Symptom management improves, quality of life improves, people have a better understanding of their illness and their prognosis. There are improvements in caregiver outcomes, such as quality of life and reduced anxiety and depression in caregivers. Mood improves for patients. End of life outcomes also improve. So there's reduced use of intensive care at the very end of life, reduced emergency department use, more hospice use, and less chemotherapy in the last 2 weeks of life. And some studies have even found that survival improves with the integration of palliative care. If we don't integrate palliative care early, or if we don't integrate it at all, there can be a number of consequences as well. So there can be underuse of things like hospice, reduced family and caregiver support, reduced psychosocial or spiritual care support. That symptom management may be not as well managed. And then we lose the opportunity to have these early conversations about goals, values, and wishes. We also see overuse of life-sustaining therapies, chemotherapy and radiotherapy towards the last few weeks of life, intensive care unit admissions, feeding tubes, and all these kinds of different invasive interventions that people may not have wanted, but they haven't had a chance to talk about what their wishes would be earlier on in the course of the disease trajectory. And so this is one of the, I guess I would call it the seminal study that really changed, or maybe was perhaps one of the catalysts that changed how we think about palliative care in oncology. And this was done in 2010 by Dr. Jennifer Temmel and her team at Mass Gen Hospital in Boston. And the authors looked at a group of patients with advanced metastatic non-small cell lung cancer, and they randomized some to receive palliative care early, and the others just to receive standard care. And what they found was the group that had early palliative care had better outcomes in terms of a lot of their, I didn't put I'm sorry, this graph doesn't mean much without the little description beside it, but a number of their quality of life measures improved. And so this is the FACT lung cancer scale. And so it's a quality of life scale. And so they had better scores, the early palliative care group. Similarly, the lung cancer subscale of this FACT scale also had better outcomes and better results in the early palliative care group. And the trial outcome index, which also looks at physical well-being and functional well-being, you can also see that the early palliative care group had better outcomes. When they looked at anxiety and depression, similarly, they found the early palliative care group had reduced anxiety and depression compared to the standard care group. Importantly, and I think surprisingly, the authors found in this study that the patients who underwent early palliative care actually had better survival compared to the patients who had standard care. And so the group assigned to early palliative care lived 11.6 months, and the group that was assigned to standard care lived 8.9 months. So, you know, a difference of a couple of months, but with advanced lung cancer, that can be quite profound. And you can see it was also statistically significant. So I think this really kind of rattled and shook the oncology world in many ways. And a number of subsequent studies also have found survival benefits for integrating palliative care early. This is the ENABLE study. It's educate, nurture, advise before life ends, and was looking at the timing of palliative care. And again, you can see in this study that there was a survival benefit for people who had palliative care integrated earlier on compared to those who had it later. This was one of the first studies that was done in a curative intent context. So the previous studies up until this point had been done in patients who had advanced cancers. And this was a study done by, again, the group out of Mass Gen in Boston. Arij Al-Jawari led the work, and was done in patients undergoing bone marrow transplant for blood cancers. So that treatment is meant to be curative. And so this was a bit different because all the other studies, or a number of the studies to date, had been in people with metastatic or advanced disease. And similarly, in this study, the authors found that the patients who received palliative care had improvements in a number of different outcomes: fatigue, symptom burden, depression, and anxiety. And these are the outcomes at, I believe this is up to 3 months. And you can see the group with palliative care had better outcomes on a number of these different measures of quality of life and symptom burden. And so more recently, there has been systematic reviews looking at palliative care compared to usual oncologic care. And you can see that a number of the green kind of color here is showing that these are the studies that favor palliative care. And so overall, you know, a huge number of studies have been done now, well, a good number of studies, I should say, involving a lot of patients. Hematology patients with blood cancers still are not showing up in a lot of these studies, so there's still some work to be done there. But you know, a good number of these studies have found positive outcomes, such as improved quality of life and improved symptom burden. The impact on survival has been somewhat equivocal. Some studies have shown a survival benefit, while others have not. And there's some question still out there as to what it is about palliative care that leads to the survival benefit. And I think, you know, each palliative care intervention study is somewhat different in terms of the intervention and the type of palliative care that's being delivered. And this is the hypothesized model, I guess, or approach as to what the relationships might be between early palliative care and the outcomes we're seeing, and particularly with a focus on survival. So maybe early palliative care can lead to, we know this, improved quality of life, better symptom control, better illness knowledge and understanding, maybe better coping. And my money would be almost on this coping piece here, that's leading to different health behaviors and adaptability, and perhaps leading to that survival benefit. David Huey and his group out of MD Anderson Cancer Center in Texas, they don't like the term early palliative care. They prefer the term timely palliative care, and I actually think that's quite appropriate. I really think that palliative care needs to be tailored to the individual that is, you know, we're planning it for. I think there's so many different factors that, you know, disease and treatment related factors, but very patient specific factors that are really important to think about as well. But this is also showing that timely palliative care, again, can help with symptom management, can help with that psychosocial support, can help with communication and decision-making that can lead to all these other downstream outcomes, that perhaps there may be some kind of interplay here between improved quality of life and symptom control. Maybe that's leading to prolonged survival. Maybe it's that people aren't having as aggressive care, and aggressive care can sometimes actually shorten people's lives. So maybe that absence of aggressive care is leading to prolonged survival. But still, there's a lot of ambiguity, I guess, and unknowns in terms of how palliative care actually leads to the survival benefit. But we know definitely that there can be profound benefits in terms of symptom management and quality of life. And so the American Society of Clinical Oncology came out a few years ago with some guidelines about integrating palliative care into cancer care. And their, takeaway from this, I guess, is that integration of palliative care is recommended for patients with advanced cancer or those with high symptom burden. And so I think this piece here is very patient specific and very subjective to the patient. So what does high symptom burden mean? And I think only the patients can tell us what that means. And so again, there's some limitations of the research that's been done to date. We need more research on health disparities in palliative care, and definitely equity in palliative care inequity in palliative care is a big deal. We also need more research on patients with blood cancers, and we also need more research on family caregivers. I think that piece has been lacking as well. So we definitely need to know how to better support family caregivers. This is a bit of an elephant in the room, the P word, the palliative care word. There's been some work done on this. And again, I mentioned early on that there's still negative stigma associated with palliative care. A lot of people still associate palliative care with end of life care. And when I go in to see patients, I can see their eyes sometimes widen and they probably wonder why I'm there. I might just be there to help manage their pain, or I might be there to help them with their nausea. But still a lot of people think, oh my gosh, palliative care is here. Does that mean I'm dying? And so there's been some work done on patient and caregivers' perspectives on palliative care. And, again, as I mentioned, that many people still equate palliative care with end of life or death. And part of this, I think, is that patients are often only presented with palliative care as a last resort. And so it's not surprising that they would think that it's associated with end of life care. And some patients in this particular study, this was a Canadian study done by Camilla Zimmerman, some participants in that study felt that palliative care should be rebranded, that we should call it something else. But one participant said, it doesn't matter what you call it, you could call it hula dancing. And eventually people would be scared of hula dancing. So I think it's all in how we brand it, how we present it, and that we explain it and very clearly tell people, no, it's not the same as end of life care. We're here to help you with your quality of life and making sure that we can manage all those things that are causing distress. At MD Anderson Cancer Center in Texas, when they changed the name of their palliative care program to supportive care, their referrals actually increased by 41%, and they did receive them in the outpatient setting more than they did prior to the name change. So there may be something to that name change. We might have to think about calling it something else. My preference, and I came up with something a couple years ago, palliative and supportive care. So you have both pieces where somebody might be more towards the palliative end of life side of things, or supportive care. Anybody could benefit from supportive care. And then it forms a fancy little acronym, PALS. So again, that play on words. We know again that we need more research on how we can better support caregivers, but we know that integrating palliative care can really help with caregivers and help with their ability to cope. So some of this support might be explaining illness, treatments, medications, because caregivers take on a lot of this. They take on huge amounts of, essentially becoming nurses and pharmacists and doctors kind of all rolled into one, and counselors, and yet still having to be the caregiver, the spouse or family member can be very, very difficult to navigate those roles. So, helping to find ways to promote self-care, helping with that partnership with the care team, and decision-making and support can be a huge piece of this as well. And then helping to ensure that caregivers have some supports for counseling and respite care so that they can get the breaks they need. And definitely practical and financial assistance is a huge one as well. And then assisting with advanced care planning, and I'll talk about that in a couple minutes. So I just did a talk recently on palliative care for patients with cancer in the COVID-19 era. And my talk was for our upcoming conference, the Canadian Association of Nurses in Oncology, and it was about cancer and COVID-19. And we know that people with cancer can be at higher risk for complications associated with COVID-19, including higher rates of ventilation and complications, and even increased mortality. And so I think now more than ever, we're really having to think about some of these difficult things. COVID-19 has kind of forced the topic. We know that palliative care can be very helpful, and so there are different centers that have protocols for people with cancer who are infected with SARS-CoV-2. And so different ways to manage their symptoms, different ways to help address some of their concerns. I don't know about the rest of you, but there's so much always in the news and the media about COVID-19. I seem to see it everywhere. These were fireworks we had on our Canada Day celebrations, and all I could see was, the SARS-CoV-2 virus, and same thing, this is dill and a dill flower, and all I could see was, the virus. But just to say that, there are definitely some things that palliative care can help with if somebody with cancer does develop COVID-19. Palliative sedation, again, is a possibility if symptoms are refractory to the different medications that we try. But again, this is where the palliative care specialist would be very helpful in terms of first helping to manage those difficult symptoms, particularly the shortness of breath, and the agitation and distress that some people with severe COVID-19 can develop. So Virtual Hospice in Canada is a great resource, and they've got a lot of different, very patient-friendly and caregiver-friendly resources on their website. And this is one that they have developed for COVID-19 and advanced illness, not just specific to cancer necessarily. And so, yeah, they've got some fancy little graphics and things like that that are quite helpful. So thinking just for a few minutes about medical decision-making and values, I think this is really important. And again, COVID-19 has forced many people to confront these difficult medical decisions. The difficulty in trying to make these decisions at a time of crisis is that very often family members don't know what their loved one would want. And so if their loved one is not able to speak for themselves, the family members are often the ones who have to make those decisions. And it can be very difficult to be put in that position if you don't know what your loved one would want. And a recent news article in one of our Canadian news outlets talked about, it was a family physician out of one of the universities in Ontario, who said planning for death in advance leads to less trauma for the dying and less stress for those who love them. And I think that's very true, even though it's very difficult to think about in advance. And so these are some things to think about when we're thinking about these difficult medical decisions. And what matters to you? I have these conversations all the time with patients. What are you willing to give up for more time? If somebody wants to make it to a particular date or milestone, that might be a really important goal. And so we'll work very hard to get that person to that date or event. But there's a trade-off sometimes. And this quantity and quality balance, I think, is really important. And the medical model historically has been very quantity of life focused, where, we're always talking about buying more time, and we're always talking about the latest advances to keep people alive longer. And I think people want to live long, and that's a valid and important goal. But if the quality of life is not there, I think that sometimes we do a disservice to people by buying more time if we can, if we're not ensuring that their quality is acceptable to them. And to be fair, some patients have described situations to me that they would consider to be worse than death. They'd rather die than X, Y, or Z. And so we talk to patients about this a lot to find out what their values are and what's important to them. What would it mean, if your quality of life wasn't what you wanted it to be? What would that look like? Would that be spending your whole day in bed? Would that mean, you can't eat or drink anymore? Would it be you can't converse with your loved ones anymore? And so those are very specific things to think about and to talk about with loved ones. And this is just a tool, an example of one on the Plan Well Guide website, where they ask people to think about what's important to them. So, sometimes, it's really important to keep pushing on with medical treatments that focus on prolonging life. And I think this, again, is very patient and individual specific. It might be very different for a young parent compared to somebody who's felt that they've lived a long and healthy life, maybe in their 90s or so. And then again, you'd be surprised. I talk to people who are in their 90s and say, no, I want everything done to keep me alive. So, and there's no judgment. There's no right or wrong answer here. It's only what is important for that person. So yeah, I think always trying to think about, and I put this in my personal directive recently, because here in Canada, we have across the country legalized euthanasia, medical assistance in dying. And we're not allowed to put that in our personal directive yet. We have to only request it in the weeks or months before death. But I did write something into my personal directive specifically to address this, to say if it becomes approved and part of the legislation where we can request it in advance, these are the things that would mean I would want it. These are the things that would make me think my quality of life is so diminished that I don't want to be here anymore. And I specifically spelled that out in my personal directive. So again, thinking about these things, this was an article that I read recently in the Journal of Clinical Oncology, and it was about it was an oncologist who was writing about a 29-year-old male who had recurrent metastatic esophageal cancer. He'd been in the ICU on high flow oxygen. He wanted to leave to go on a trip with his father, initially to Las Vegas, but settled on a casino 3 hours away. And his oncologist talked about many possible outcomes of going on a trip. And she wrote in the article, I began my conversations with Josh, assuming that either he had not thought of these things or that he was in denial about the severity of his illness. Thinking back to our ventilator talk, however, I gradually realized that he was not, generally speaking, that sort of patient. I began slowly to wrap my head around the fact that this patient was not afraid, at least not of the things that I feared on his behalf. It was not that he didn't believe the scenarios I presented to him. To him, dying on the floor of a casino after a great night out was not the worst possible scenario. Dying in a cage in our ICU, the last days of his life orchestrated by others, waiting around in the least fun place on earth for his time to die was what scared him. So I think we really need to, and this was a 29-year-old patient. So, to him, he had in his head what was pretty clear in terms of what his goals were. We as healthcare professionals really need to be asking and listening and respecting those wishes. Quickly, I'll talk about advanced care planning. Again, this is something that gives people an opportunity to talk about their goals and wishes in advance, not in a time of crisis, so that family members and loved ones know what somebody would want. And again, we talk about this, and we've heard about, this is Nathan Gray. He's a palliative care doctor from Duke in North Carolina. I'm pretty sure it's North Carolina. And he does all these great cartoons and things as well. So, there was stuff going around in the media a few years ago about people tattooing on their chest DNR and their medical wishes. It's much more than that. It's much more nuanced, these conversations, and there's far more to it than just don't resuscitate me or de-resuscitate me. And advanced care planning, really, it is a gift for everyone. Really, it's a gift for patients, it's a gift for caregivers and family members. It's really important that people's health wishes are made known. It improves their end-of-life care, and it really removes a lot of that burden for family members, which can really positively impact bereavement outcomes as well. So this is an analogy written by a couple of palliative care doctors in the States, out of Texas. And they use this analogy of, if you're going on a car trip and you're hopeful and unrealistic, nothing bad's going to happen. You don't plan, you might have some issues, or you're hopeful, but you're also realistic. So you have all these comfort features and safety features and things. So if you encounter these bumps in the road, you're better prepared. You're going to have a better trip. And to put that into the healthcare context, we all would like to think that, nothing's going to happen and we don't really need any of these things in place. And it's kind of Murphy's Law. If you set these things up, there's a possibility you may not need them. But having a hopeful yet realistic attitude can allow and ensure that these safety or these comfort and safety features are put in place in advance, so that if these bumps in the road are encountered, there's going to be a much easier transition and a much easier experience for everyone involved. And Eric Rowland is a dually trained and board certified palliative care and medical oncology physician in Boston. He works at Mass Gen. And, he presented this a few years ago and I really liked it. So, expect the unexpected, plan for emergencies, but keep hope really central. And, it doesn't mean that just because you're planning for these things that you have to give up hope at all. And somebody else, I can't remember if it was him or someone else at that conference, said, worst case, best case, most likely. And so when you're speaking with your physicians about these, difficult medical decisions and things, and every patient is different, every person's different in terms of the amount of information they want to receive. But I like to ask people or tell them if they want to have that information, worst case scenario, best case scenario, most likely scenario. We don't have a crystal ball. We don't know how things will go for sure. And that's why I think it's always important to ensure that we are preserving or maintaining hope, but also ensuring that people are prepared. And just to give an example of medical decision-making, CPR, it's not like in the movies where they punch or tap on your chest for a few times and then the person sits up and starts talking. If we took 100 healthy people and they had suffered a cardiac arrest, out of that 100 people, only 18 would survive and leave the hospital. If people have serious illness like cancer, heart disease, or kidney disease, only 10 would survive CPR. And if people have a critical illness or in the ICU, only 2 out of the 100 would survive. And age is also a factor as well. So over the age of 75, only 15 out of 100 would survive. And of those who survive CPR, a quarter of them will go home independently, a quarter will go home but require help at home, and half of them will need to live in an institution like a nursing home or rehab center. About half of them will have problems with memory loss, cognition, and difficulties trying to get things done. There could be a lot of other things and consequences as well. So yes, definitely CPR might prevent immediate death, and there's a chance of returning to previous function. But there can also be high rates of stroke and brain injury, risks of broken bones and bruised lungs. It will not fix the underlying issues. So whatever led to the cardiac arrest, that won't magically be fixed just because we got the heart restarted. And there may need to be a lot of care from family or home care in order to return home. But the other side of the coin, no CPR, that means that someone will pass away. And so, you lose out on that small chance of prolonging life. And again, we don't have that crystal ball to know if we can prolong that life or if we can save that person, what that life is going to look like in terms of quality. So these, again, are really important things to think about and talk about with your loved ones. So different organizations, of course, have come out with resources and things to help. And again, decision-making in the time of COVID-19 is very important because people who get ill with COVID-19 can be doing fine, and then all of a sudden they're in respiratory distress. And so I think medical decision-making now is even more important than ever. And so this is just an example of talking about your wishes and things like that, and writing it down and making sure that somebody close to you and important to you knows what your wishes are, and also communicating that with your healthcare provider as well. So debunking the myths, I guess. I hope I've convinced you. We've heard before palliative care will shorten someone's life. No, that's not the case. And certainly even our medical assistance in dying in Canada is quite separate in many ways from palliative care. And there was concern that if palliative care provided medical assistance in dying, that people might think that, oh, palliative care is here to, shorten my life or convince me to stop my chemo. And that's just not the case. We can be involved and help people even through their chemo. And we know that there's high quality of research that's shown that palliative care has led to improved survival and also improvements in quality of life. And this is another myth. And so it used to be, again, that we reserved palliative care for that time when disease-directed therapy was no longer being offered, but that's not the case anymore. And there's evidence to suggest that we should be integrating palliative care from the time of diagnosis onward. And, there's nothing to say that we still can't provide chemotherapy or radiotherapy. And I've spoken before to different hospices to ask them to allow somebody to continue with their chemotherapy in hospice because it's providing symptom benefits. So it's helping with bone pain, or it's helping with various different symptoms, that intent of that chemotherapy is to relieve symptoms and improve quality of life, it's definitely appropriate to continue in hospice. And I hope I've convinced you that palliative care is not the same as hospice care, that hospice care is a type of palliative care, but that palliative care is not the same. So yeah, just to summarize quickly here, because I see that there are some questions. So recent research has shown that palliative care can improve quality of life and also can improve survival in some contexts. Palliative care should and can be part of routine oncologic care from time of diagnosis through to bereavement. Palliative care provides relief from symptoms, physical symptoms, helps with psychosocial symptoms as well, and existential and spiritual support, can provide assistance with advanced care planning and helping with prognostic understanding and illness and treatment understanding, supports the whole person and their family and loved ones, and really helps people live as well as they can for as long as they can. I put this picture down here. I know if you Google search images for palliative care, I guarantee you all you'll come up with is images of people holding each other's hands. And somebody had written a paper a few years ago about this, saying we need to change that image for palliative care. So I'm starting to incorporate pictures of mountains and things like that. So just to close with this quote from Atul Gawande, who's written a fantastic book called Being Mortal. And he says, "The battle of being mortal is the battle to maintain the integrity of one's life, to avoid becoming so diminished or so dissipated or subjugated that who you are becomes disconnected from who you were or who you want to be. Sickness and old age make the struggle hard enough. The professionals and institutions we turn to should not make it worse." I share this with my colleagues and with medical professionals when I do talks on palliative care, that we really need to be listening to patients and their loved ones and really respecting their goals and wishes and making sure that we are not making things worse. A bunch of different resources available to help with medical decision making and palliative care resources. And these are some fantastic books that are about palliative care, and some of them are more focused on end-of-life care, but definitely address some of the issues and concerns that we see in serious illness. And I'll just leave you with my contact info. And this was something my daughter, 9-year-old daughter, had made early in the pandemic. These are all little shells that she's collected over the years, and she came up with this herself, just this little message of hope. And I hope that I have left you with that today, that palliative care is meant to be hopeful. It's meant to be helpful. It's meant to help people live their best lives while they're here and they're still living, and also meant to support caregivers and loved ones and help ensure that that transition is as easy on everyone as possible. So thanks so much for your attention, and I will take a peek here at the questions. So I'm hoping, do you know, Miguel, can everyone see the questions? I don't want to breach any confidentiality.
Miguel, you're on mute.
Yes, okay. I don't know. Daria, does everybody see?
I don't know. What I've been doing is kind of paraphrasing the questions.
Yeah.
So yeah.
Yeah. So there are two posts. They're not questions. One of them is from the UK, and he was told about using palliative radiotherapy treatment for painful meds in the context of pain relief management. My disease is incurable, but purely the option of managing pain and thereby quality of life has changed my psychological view of my prognosis. And I say this as a psychologist. Not a question, I know, but good to see early palliative care being embraced in the UK at the Royal Marsden.
Yeah, thank you so much for that comment. There's been tremendous work done at the Royal Marsden. Definitely some leaders in the world for sure in palliative care. And again, I think there's that notion that when we shift the goal from curative intent treatment, we're not abandoning people. We're not, we're just shifting the focus. And I think we need to find out from patients what that change in focus should be. And sometimes it is, I want to stay at home as long as I can. Sometimes it's something like, I want to make it another 3 months to make it to somebody's wedding that's really special to me. And sometimes it's something like, I just want to be able to, stay at home with my cat and, watch my favorite movies from time to time. Whatever it is, we need to find out what those goals are. And then we work just as hard as we were working at treating the cancer, on trying to make that quality of life and those other goals, realized for the person. And I think we can do that in many, many circumstances. There are some situations where symptoms can become refractory to treatment, meaning they're very difficult to manage. And even in those circumstances, we have interventions and things that we can implement to help alleviate the suffering. And so I really feel that there's so much that we can do, and that again, we shift the focus, we shift the efforts. And I've heard so often people say there's nothing more that can be done. And I hate when I hear those words, because there's always something that can be done. We can always be doing more. And definitely palliative care is an example of very comprehensive care that can really address a whole person suffering.
Yeah.
So yeah, go ahead.
So
Yeah.
I wanted to add, as a caregiver, and myself also cancer survivor, the palliative care it eases the burden on the caregiver, in terms of at least they don't have to feel like they have to do everything and try to solve everything. When the palliative care is offered, I see that it supports the family and the caregivers and those around them.
You're so right about that. And I had a friend, he lost his wife a couple years ago to colon cancer. And, he was so stoic and he was trying so hard. And she initially had wanted to stay at home as long as she could. And he was, as you know, caregiving it's a 24/7 job. And it is very burdensome at times, and it's and then you're feeling guilty for feeling burdened, and it's a very, very difficult, physically, emotionally, psychologically. It's very difficult to be in the caregiving role. And so, there came a time when his wife was very unwell. He was having a hard time managing her pain, and she was up through the night. And I tell people very often, if you accept the help from palliative care, if it's palliative home care or if it's a hospice facility or something like that, that extra help then allows you to step back and just be the spouse, just be the husband, just be the daughter. You don't have to worry about medication schedules anymore. You don't have to worry about, toileting and all the different things that we expect of caregivers. You can just step back into that role that you'd been for so many years before you were forced to be pushed into that caregiver role. And particularly at end of life, I think shifting back into that role to just be there as a family member and not have to worry about the pain meds and not have to worry about, am I doing enough? Am I doing it right? Am I messing this up somehow? It's a lot of burden. And so to step back and just be in that family member role can really make a huge difference, I think, on that experience for the caregiver or loved one.
Definitely.
I want to give a 10-minute warning here just for everybody's benefit. And Miguel, I don't know if you saw, but we do have a person with their hand raised who would like to ask a question.
Yes, that's what I was going to point out, that somebody else also, no question. They just want to thank you for the session. I was recently referred to palliative support care, and I had the deer in headlights look. Am I dying that soon? This session has helped me overcome my fear and getting the care I very much need as my cancer has spread and progressed.
Yeah, thank you so much for that comment as well, because again, I see that deer in the headlight look. I just did a study where I interviewed patients going through bone marrow transplant for blood cancers. And, again, so many of them said that if they would have been referred to palliative care, if palliative care would have come into the room, they would have had that deer in the headlights look, because they didn't understand what palliative care was. And they would have thought, oh my gosh, am I dying? How come nobody told me? And it would have caused a lot of anxiety and distress. And so I think that, we have a lot of work to do as palliative care clinicians in terms of educating the public, but also other clinicians, other doctors and nurses that I work with sometimes don't understand palliative care. We also interviewed doctors and nurses and psychologists in that study I just did. And many of them also still think of palliative care as end of life care. So clearly we've got some work to do yet to educate the public and also healthcare professionals as well.
Nice one.
You've done such a wonderful job, Reanne.
Yeah.
You know, you've given a lot of people peace of mind in terms of understanding it. So I think, you know, you've covered it all. Doesn't seem that there's any more questions.
Well, and you know, if people are not comfortable asking questions in this matter, I'm happy for people to email me. I'll answer any questions via email that you might have. But I do hope that I've convinced everyone that palliative care is not a scary term, and that we should all be having these conversations. And particularly, I think, as I mentioned, you know, COVID-19 has really pushed this to the forefront of people's minds, and it's out there a lot more. We're hearing a lot more about you know, ICU care and ventilators and those really important medical decisions that people have to make sometimes at a time of crisis. It's much easier to have these discussions in advance with your loved ones to make sure that they know what you'd want, because it can be so scary and so challenging to make those decisions at a time of crisis. So yeah, in my family, you might imagine, so as in the introduction, as Miguel mentioned, that a lot of my work has been on sexual health and cancer. And now I've, in the last decade or so, have moved into palliative care. So sex and death, you know, kind of the big taboos in our culture. And yet I talk about them quite readily and openly with people. And in my family, I, you know, have these difficult conversations all the time with family members. And it can be awkward at times, for sure. But my goal is always quality of life and improving the experience of life and death, because this is something that, you know, we're all going to face at some point with loved ones and even with ourselves. So really thinking about and talking about what we would want and trying to make that experience as good as possible for all involved. So thanks to everyone for attending today, and thanks to Daria and Miguel for moderating and assisting. And as I said, please email me if you have any questions.